we'll go on to the topic. So today we'll be seeing about imaging in facial trauma. It's facial, or it's usually called maxillofacial trauma. So I hope everyone had seen the anatomy and come. Like if not, you can go and read the anatomy. The anatomy is extensive. You know that facial bones have paired, unpaired bones. There are around 14 bones in the face. So we are not going to deal about the anatomy per se, although when we see the related fractures, I'll be touching upon the anatomy. But it's always a good idea to know the bones and the sutures that forms the face. So going to the topic proper. So most common fracture as far as facial bones are concerned, nasal bone is the most common fracture. And for obvious reasons, males are more commonly affected compared to females. And in most of the cases, there will be bilateral fractures. This is because the force on one side dissipates to the other side. So it is usually seen in a segmental fashion, predominantly in mandible. If you see, most commonly you can see there will be two fracture lines. So it's kind of a contra coup force that acts. And also, whenever you see a facial fracture, you must remember that there can be an associated fracture of skull base or cervical spine. So because all these regions are correlated, so they are nearby to each other. So it's always it's good to remember that whenever you see a fracture of one single region, you have to go and search for other fractures in the other two regions. Slide number. So I'm in the second slide, epidemiology. So is it visible, the slides, the video, everything? So again, yeah, we'll take a repetition. So I have said nothing. The most common is nasal bone fracture, as it is in the slide. Bilateral fractures are relatively common compared to other systems. It's because the force on one side usually dissipates on the other side, and it is especially seen in mandible. And whenever you see facial injuries, you have to look for skull base and cervical spine fractures. And our goal should be to look for the fractures first, to identify what all bones are fractured, and then you have to give extra importance to the functional areas. So functional areas is nothing but the face contains all the six, like it has a lot of cranial nerves, and it has important sensory organs and special senses, like it has orbit, which encases the eyeball. So that is one functional area, and it has the paranasal sinuses, it has the nasal bone, the nasal cavity, and mouth. So you have to give extra importance to these functional areas because that is where the management role comes in. So the surgeon would want to know like what are the functional areas involved, and it will also be easier for the treating physician, like whether it's the emergency physician or the primary physician, to refer the cases to respective doctors. So for example, if it is an isolated fracture of orbit, so they'll be calling the ophthalmologist. So it's always a better idea to give the most important information in the first part of the report. And like the other non-significant fractures, you can just mention it. So that is one thing. And also, it is very important because it deranges the cosmetic appearance of the patient. So you have to, especially even nasal fractures, even though it is more common and most of them will be a minimally displaced or undisplaced fracture, it's always a good idea to mention the number of fracture fragments, whether it's comminuted or not, and whether it's involving the septum or not, because they'll take an extra care to look for the nasal septum. So most commonly, there will be septal hematoma. So if it is left untreated, it can result in future septal perforation. So these are the things, and it's always prudent to mention the most important findings, and the vocabulary should be like it should be in concordance with the treating surgeon. So it varies institution by institution. So you have to follow what the treating surgeon, whether it is the ENT surgeon, plastic surgeon, OMFS. So there has to be a concordance between radiologist and the treating clinician. So modalities, computer tomography, that is CT is the workhorse for trauma. So in the previous classes also I have said this, like for trauma, CT is the workhorse. Although radiography and OPG, orthopantomogram, has special indications, especially in nasal bone fractures in resource poor settings, they usually order an radiography first, and the radiography that is ordered is the lateral view of the face. So in that you can very well appreciate the nasal fracture if it is present, and OPG, especially in mandible fractures. So if the patient has a low trauma, like low energy trauma, and if he or she presents to the dental department, they usually do an OPG first, and then the patient, like if they are suspecting like any other fracture, then the patient comes to the emergency department or the radiologist. So this is the lateral view of the face radiography. And here you can see there is fracture of the nasal bone. So most commonly, it will be an undisplaced or minimally displaced. So whenever there is symptoms out of proportion, the patient, the clinician will order for a CT to look for other associated fractures. And this is an orthopantomogram. In this, you can see there is fracture of the mandible. So we'll come to the classification later. Now I'm just going to the modalities. So one important thing is whenever there is involvement of the alveolus, it is treated as an open fracture, because as you know, mouth is not a sterile area. So it obviously communicates with the external environment. So it's considered as a open fracture. Because in management also there will be an high chance of high risk of infection. So in the post-operative period, so it is considered as an open fracture and it's treated accordingly. So that is one thing you have to remember whenever you deal with maxillary alveolus and mandibular alveolar fractures. And coming to CT, the criteria that is used is Wisconsin criteria. So the sensitivity and specificity is not that great compared to the cervical spine, lumbar spine, and the head trauma that we use, the criteria that we use for the other regions, because the sensitivity is around 60 to 70%, and specificity is also around 50 to 60%. But for theory, you need to remember the criteria that is used whenever the patient has these 5 things. The clinician can order for a CCT of face. Like most commonly, CT non-contrast is enough. So whenever they order with other torso trauma, so CCT will be done. So it's whenever there is a bony step off or instability, so we'll see what are the instable fractures, and whenever there is periorbital swelling or contusion. So why, if there is periorbital swelling or contusion, it will be very difficult for the clinician to look for any fractures. So there won't be, there will be crepitus, emphysema and all. So to evaluate for the underlying bony regions, so they order for face CT. And whenever there is GCS less than 14, so usually patient won't be responsive. And whenever there is any tooth absence, to look for tooth fractures and alveolar fractures. And whenever there is malocclusion, that means there is involvement of maxilla or mandible. So whenever these characteristic features are present, then at least one should be present to get a CT face done. So the field of view is usually from the frontal sinus to the mandible. So this covers all of the face. But in high energy trauma, usually this will be combined with the CT of head and cervical spine. So this is the FOV. And before moving on to the anatomy, the rest of the modalities, main thing is MR. So MR, it won't be done in an acute setting, and like there is also higher risk of foreign bodies, so there will be artifacts. So MR, there are 2 niche indications. One is whenever there is involvement of the base of skull, and especially in the frontonasal and frontomaxillary regions. So whenever there is fractures of these regions involving the cribriform plate, so there is a high chance of CSF leak. So if the patient has an watery discharge, clear watery discharge, so usually cystonogram, MR cystonogram is requested, and it won't be done in immediate setting. So if you are able to see a fracture, like a clear fracture of cribriform plate, obviously they'll repair that. So that will be the only cause of CSF bleed. So when there is multiple fracture and when we are not sure where there is the leak of CSF, then an MR cystoscopy will be ordered once the patient is stabilized and once all the important fractures, other injuries of head and cervical spine are managed. So only after that, there will be a requisition form for MR cystogram. And other thing is they also do a delayed scan whenever there is to look for involvement of the optic nerve. So especially in fractures of uh, orbital apex superior fissure fractures. So in those cases, MR has an additional role to look for the optic nerve. So optic nerve can although in CT it looks normal, in MR it can depict the edema, or if there is hemorrhage, it can show blooming on gradient images. So that is one indication. And the last thing is the DSA, so digital subtraction angiography. So it can be both used for diagnosis and therapeutic purposes. But in the current era, so we use CT angiography. So the diagnostic role is very less. The therapeutic role, it plays a very important role in therapeutic approach of epistaxis, bleeding, post facial fractures. So whenever the patient is very unstable and there is dire need for blood products, so they usually refer the patient to IR department. So most common artery to bleed is the internal maxillary artery. So this is one thing you need to remember from this class. So if they are not able to find bleed from, like, if the patient is like very unstable, so they do a prophylactic embolization of internal maxillary artery. Okay. Yeah. So before seeing the separate fractures, we need to divide the regions. So it's always a good idea to divide the region that we are studying so that it will be easy to remember and also easy to apply. So like there are two concepts. One is used by ENT surgeons. So they usually refer to the facial fracture as upper face, mid face, and lower face. So upper face is nothing but, so it includes the frontal bone and the frontal sinus, and the superior orbital margin differentiates the upper and mid face. And mid face is the most important region. So it results in a lot of complex facial fractures. So that is the most important region. It is the region between the superior orbital rim and the maxillary alveolus. So this is the maxillary alveolus. So you can say if it is not visible, I'm using yellow color. So if you're not able to see, you can always reply in the message box. Yeah, I know. Yeah. So upper face is nothing but the region above the superior orbital rim. Mid face is the region between superior orbital rim and the maxillary alveolus. So the region below the maxillary alveolus is nothing but mandible. So mandible is included in lower face. Frontal bone and frontal sinuses are involved in upper face, and all of the rest of the other regions are involved in mid face. So in mid face, important structures are, one is the first one is the orbit, and next comes the nose, paranasal sinuses, maxilla, and also posteriorly if you go, you can see the ethmoidal sinuses, ethmoidal and sphenoidal sinuses, and also the pterygoid plates. So it's a three-dimensional structure. So it's very difficult to categorize and classify, like both diagnose and classify the fractures. So you need to remember two things. Face is connected to the skull by two structures. So posteromedially, it is connected by the pterygoid plates, and posterolaterally, it is connected by the zygomaticotemporal suture. So I'll just draw here.